good evening, good afternoon. I get confused because there's a different time zone I'm calling for. So we have a live session on 118th CMAAO International Weekly Meeting, and we are joining in from various countries. We come across with a lot of various topics and discussions, and COVID is again increasing with a lot of countries. So we have a lot of questions and concerns about the vaccinations, the combinations, the booster, how many boosters are required, when to take a vaccination. So again, today we have a COVID update vaccination as a topic. And to talk about this, we have our favorite speaker, Dr. Monica Vasudev. She's from US. She's an expert on allergy and immunology. She's in internal medicine. She works with Advocate Arola Health in USA. Over to you, Dr. Monica.
Okay, thank you once again, Saurabh, and thank you to this August group that get to share ideas, thoughts, and updates on where we are on emerging diseases like monkeypox, and to talk about the pandemic that we continue to live in and which continues to evolve. It's been some time now. It's been some time now since I've given any update regarding the vaccines, and I thought this was a good point to talk about the vaccines because of a recent FDA advisory committee meeting that had happened on the 28th of June, where some important decisions were being made with important data being presented. So after hearing the news about the meeting from June 28th, and which the results were released to the public on June 30th, I put together a few slides. I do not think that this is exhaustive in terms of covering the breadth of all the questions that you might have. For full disclosure, I put this together in the last 2 hours. So I don't have all the answers necessarily with data to all the questions that you might have, but I think this is a good point to rethink our approach to vaccines now that we are further in the pandemic. So the title of my talk today is COVID vaccines and shifting to a long view about the use of these vaccines. So I'd like to start my presentation by talking about the share of people who have completed the initial COVID-19 vaccine protocol as of the 7th of July of 2022. And what you can see is here are that the darker shades of green are representing those with a higher percentage of those who completed the initial series, whereas those who have in the yellow shades to beige, where you're seeing a much lower rate of vaccination. So this is a graph or a map that is very different than a map that I would have shown several months ago. And with time and with access to vaccines, and we are seeing more of countries being vaccinated with a very obvious lack of vaccine resources. And that was in Africa. So on June 21st, 2022, the following news release was made that a South African biotech company, Afrigen Biologics, will work with a Belgian partner to develop the first African-owned COVID-19 shot as a broader effort to reduce the continent's reliance on other regions for vaccines. They'll seek to develop vaccines that are cheaper to produce, easier to store, and to distribute in rural and remote locations where few people have been vaccinated. So that's just a nod to vaccine inequitable distribution and trying to address that. So as a review, where are we today as of the approved or authorized use of vaccines in the United States? For those who are 18 and older, those that are approved and authorized and currently available include Pfizer-BioNTech, Moderna, which are your mRNA vaccines, your vector vaccine, the Johnson & Johnson Janssen vaccine, those approved for age 12 to 17, Pfizer-BioNTech, Moderna, and those 11 and under, which is the Pfizer and the Moderna. This is, as of June, have been approved down to the age of 6 months. Oops, sorry. So for those 6 months and older, going a little bit more into the Pfizer-BioNTech, the primary series for 5 months and older, 2 doses given 3 to 8 weeks apart, who are not moderately or severely immunocompromised, and can get a 3rd dose, so that's your first booster, 4 weeks after their 2nd dose in the primary series. However, if you are under the age of 5 and you're 6 months and older, you can get 3 doses that are separated, the first 2 by 3 to 8 weeks. And the 3rd dose in this age group is 8 weeks. Boosters 5 years and older, those who've received Pfizer should get a booster. Only some can get a 2nd booster dose. And 6 months through 4 years, a booster dose is not authorized in this age group. So Moderna, this is also known as Spikevax, recommended for age 6 months and older as well. For those who are 18 and older, there are 2 doses of Moderna in the primary series, given 4 to 8 weeks apart. Those who are immunocompromised should get a 3rd dose, with the 1st and 2nd doses separated by 4 weeks, and the 2nd and 3rd doses separated by 4 weeks. For age 6 months through 17 years, 2 doses of Moderna in the primary. People who are moderately or severely immunocompromised should get a 3rd dose. So this is different than the Pfizer series. And then the booster dose is for 18 and older. People who've received a Moderna should get a booster. Only some should get a 2nd booster. And if you're 6 to 17, currently a booster dose is not authorized. And more information can be found on the CDC website regarding this. And also, as you can see, there's these buttons at the bottom that you can click. For the Johnson & Johnson, for some situations who are 18 and older, the recommendation is the preference of the mRNA vaccines, and they should only be considered in some cases, and it should not be used as a 2nd booster dose. Primary series is 1 dose, but they should also get a 2nd dose following up on the Johnson & Johnson after 4 weeks, BioNTech and Moderna. And then boosters should get a booster dose. So you might have heard in the news that the Novavax vaccine, this was from the FDA meeting. It showed demonstrates broad immune responses, including against Omicron and other circulating variants. The preclinical data demonstrated that boosting with Novavax, Omicron, or prototype vaccine gives a very strong immune response against the Omicron variants, including the BA.4/5, which I'll talk about later. The Novavax is currently approved, but not available to be administered. It will come in the fall in accordance with the FDA Advisory Committee's recommendation. There was a little bit of a delay because there was a change in their manufacturing process. Novavax contains the spike protein as opposed to the mRNA, vaccines that contain the genetic code to create the spike protein. It's made by turning insect cells into protein-producing factories that then require processing and purification. And there's also a major difference in the level of refrigeration required. It's more like the Johnson & Johnson in that it only requires regular refrigerator temperatures. The mRNA vaccines, as you recall, really require colder temperatures to maintain structural stability. So let's talk about now about the impact of these vaccines and what the more recent data is. So this was data that was published end of June, beginning of July. And sorry, the title got mistyped here. In 2021, COVID was the #1 cause of death in Americans aged 45 to 50. And what you're seeing here are 4 graphs of 4 different age groups. The first top left is for age 25 to 34. This is 45 to 54. The third is 65 to 74, and the fourth is over 85. And in each group, you're seeing the 2 sets of bars. The first is between March, beginning of the pandemic, 2020 to December. And then the second group of bars is between January and October 22nd. If you can see in ages 25 to 34, the #1 cause of death in that age group is accidents in both those time points. However, in those between 45 and 54 years, between March 20 to December 2020, the #1 cause of death was either heart disease or cancer, whereas in between January to October of 2021, you now see COVID-19 in this gray bar as being the #1 cause of death. Age 65 to 74, you're seeing cancer, and over the age of 85, you're seeing that it is heart disease. So this is the impact of the disease in terms of cause of death. What we know and what we've seen, as you can see, this is now data that's just published from 2 days ago. Vaccines do prevent death. And this is looking at the number of COVID-19 death prevented among vaccinated persons in December 2020 to September 2021. So pretty much in a similar time frame as the graphs that I'd shown you earlier. So here the CDC estimates that 1.6 million hospitalizations and over 200,000 deaths were averted. They were avoided due to the vaccination until the fall of last year. Most of the hospitalizations and deaths prevented were in the age group of 65 and older, with 759,000 hospitalizations and 154 deaths prevented. In the 58 to 64 age group, followed closely behind with 525,000 hospitalizations and 66,000 deaths prevented. So we're seeing that the benefit of the COVID vaccines in the older age group, over 50, was effective in both hospitalization prevention as well as preventing death. For this study, they used a multiplier model to extrapolate the number of infections and COVID-associated deaths from data on the number of COVID-associated hospitalizations. And they broke it down by state, month, and age group from December to September, factoring in the official start of the US vaccination program on December 12, 2020, as well as staggered subsequent rollouts. So that was the US data. What about the international data? And when the first year of COVID vaccinations, it is estimated that over 20 million deaths were prevented worldwide. And this is data that's coming from 185 countries. And that another 600,000 lives would have been saved if we met the WHO benchmark of 40% immunization, which was not achieved. So here you can see the deaths averted in this graph B in this panel. And these were deaths averted by vaccination per day. And that's on the y-axis. On the x-axis, you see different time points along the pandemic: January, April, July, October, and then finally January 2022. And what they've also shown you is the deaths averted by different countries, such as high-income countries, which is in your purple. In this blue color, you have the upper middle, and then in the green, you have the lower middle countries. So we are seeing the effect and the deaths that were prevented by COVID vaccination. So another way, a much easier way to have seen this in terms of global deaths, is looking at the number of deaths based on excess mortality due to COVID-19. And these are numbers that are represented in the thousands. And what you can see here in the salmon color are the deaths that were averted due to vaccinations. And this is really why we still continue to talk about vaccinations, because it is showing us that it is preventing death. So what about the younger group? I did say that that now these vaccines, at least in the US, are approved down to lower and lower age groups. And this is data that's coming from Israel. This is also recent data. And what it is an observational study. And they looked at protection against Omicron in ages 5 to 11 following a single dose of the vaccine. And then they found that there was protection, so minimal protection with a single dose. But when you got your second dose, 14 to 27 days after the first dose, there was a 50% protection against Omicron. What about vaccine effectiveness for infection? It was 17%, and prevention of symptomatic case was 18%. The vaccine effectiveness grew to 51% and 48% respectively in the time following the second dose. So what we are seeing is that with a single dose in this age group, not very effective, and that the efficacy of the vaccine improved 2 to 3 to 4 weeks following the second dose. Okay, so let's talk about the survival advantage of a fourth dose. And now this is the question, is like, should we get a second booster dose? There has been some hesitation. I've gotten my initial series, I got COVID, it felt like a mild flu. Why do I need a second dose? So this is the data that was recently shown about the survival advantage of a fourth shot or the second booster for that age group that's 50 and older. What I've shown in the top right-hand corner are the current recommendations from the CDC website regarding who gets one booster and who gets two boosters. And remember, the primary series can be 1, 2, or 3 shots, depending on which age group you are in and which vaccine you are getting. So a booster is recommended for anyone 5 and older should get one booster after completing their primary series if they're eligible. And 2 boosters are recommended in the US for age 50 and older, and for those who are 12 years and older and who are moderately to severely immunocompromised. So what you're seeing here on the left is a graph that shows you those who have the death rate incidence per 100,000 population if they are unvaccinated, as demonstrated in this black line here. If you've received the primary series, you're seeing that in the blue dotted line here, and you can see that you're starting to see that this number is starting to rise. If they've gotten the primary series plus 1 booster dose, you're seeing this in the dark navy blue line, and you're seeing now that that line is approximating that of those who've received the primary series. But the best benefit was seen in those who've received the primary series and have received the second booster dose. And now this is looking at positives based on positive specimen collection at the end of March and the beginning of April. So that is during our Omicron surge here as well. So in April 2022, among people who are 15 older, unvaccinated people, so those who are in the black line, had a 42 times risk of dying from COVID compared to people vaccinated with a primary series and 2 or more booster doses. However, among those who were 15 and older with a primary series and 1 booster dose, so they didn't get the second booster dose, they were still 4 times more likely to die from COVID than if they did not get their second booster dose. So when you get approached by, well, why should I get the second booster dose? I already got my primary series. I already got 1 booster dose. A second booster is being recommended. This is the data that you can show that you are 4 times more likely, especially in the 50 and older group, to die of COVID in this current part of the pandemic if you've not received your second booster dose. I believe that this data is compelling and provides the rationale for getting a second booster dose. So There was another study that had come out recently that looked at, that was in the Lancet, about vaccines and death prevention across BMIs. So here they looked at unvaccinated, and then they looked at vaccinated individuals in each BMI group. And what they found is that there was a significantly lower likelihood of COVID-19 related hospitalization starting 2 weeks from their second dose if you were underweight, normal weight, overweight, or obese. Likewise, if vaccinated people in all BMI groups also saw a significantly greater protection against COVID-related deaths if you were underweight, normal weight, overweight, or if you were obese. There was a comment from this publication that we saw that their lower weight individuals were less likely to get the COVID vaccines and were at risk, and that those across all BMI should be encouraged. This was maybe related to the fact that obesity was listed as one of the risk factors from dying from COVID vaccine, and perhaps that played a role into factoring when people decide how to risk stratify their need for a vaccine during the pandemic. So what about vaccines and long COVID? And so this publication came out a week ago. I'm really showing you the most recent of publications and knowledge. This was a longitudinal study. It was observational that was conducted among healthcare workers in Italy with SARS-CoV-2 infections not requiring hospitalization, who had received 2 to 3 doses of vaccine compared with no vaccine. And what they found was that those who were vaccinated had a lower risk of long COVID, or had lower long COVID compared to those who were not vaccinated. So another reason for vaccination. So this was another conversation that we started to have before today's meeting, and that was talking about vaccine hesitancy. So this was a very well-written editorial or review article, by Dr. Larson in the New England Journal of Medicine. It was on the vaccine hesitant moment. And she reviews all the different vaccines that came out and when it was related to the information that was being disseminated or misinformation that was being disseminated related to these vaccines. And I found this timeline to be very elegantly summarizing the different time points in terms of the Lancet Wakefield paper, and when different social media and digital technology events took place. Google in '98, Facebook in 2004, YouTube 2005, Twitter 2006, WhatsApp 2009, Instagram 2010, Snapchat 2011, Telegram 2013, and TikTok in 2016. And that is in respect to the different medical events, such as removing thimerosal from childhood vaccines in 1999, following the link to autism and with thimerosal. Approval of the FDA HPV vaccine and its response with respect to different social media platforms, the initial H1N1 pandemic, the measles outbreak, and then now the COVID-19 pandemic. Finally, at the end of the paper, she says that physicians and other healthcare providers are still among the most trusted persons when it comes to healthcare. And the Wellcome Global Monitor surveyed people in 140 countries and found that 73% of the respondents said that they would trust a doctor or a nurse more than any other person when it comes to discussing vaccines. The percentage was 90% in higher income countries. So vaccine acceptance can increase, but healthcare providers, that's us, we need to offer our support and encouragement and to listen to what matters from the patient's perspective. So equipping us with information on the nature and scope of circulating concerns and their communities may help them address such concerns in the clinic, while also informing appropriate interventions at the community level. So this is a map that looks at the rates of vaccine hesitancy across different zip codes as of December of 2021. And it's breaking it to rates of vaccine hesitancy to less than 0.15, which you can see here in the coastal areas. And then as you're going in here, you can see more of the reddish areas. So what's another reason that people have hesitancy? And that's related to side effects. Now, these are the listed CDC side effects that you can find online, which is, common side effects with any injection is pain, swelling, and redness at the injection site. But you can also have systemic symptoms, and this is due to interleukin release. This is due to any sort of immune activation. These can be similar to having an infection, and that's fatigue, headache, myalgia, fever, chills, and nausea. Now, there's a whole host of other skin reactions that have been talked about before, including the Moderna arm. I have had patients that have come to me, their onset of either COVID vaccine COVID infection or following vaccination was a recurrence of urticaria or hives. There are people who had worsening of eczema. I look at that as not vaccine specific, but related to immune activation as a result of the vaccine. Specific side effects or concerns for reactions are being collected on a voluntary basis that can be entered. The data can be entered by almost anybody through the Vaccine Adverse Event Reporting System, or VAERS, in the US. There have been multiple attempts in the world of allergy to be able to characterize. It was thought that maybe polysorbate or polyethylene glycol were responsible for some of the reactions. There were recommended testing protocols utilizing surrogates of these different constituents of the vaccines or excipients. And at the end of the day, we've come back to not being able to have a clear idea of way to troubleshoot. I've had patients who've reported side effects after the first dose and went on to receive the second dose, which they were able to tolerate. So I think that we are still waiting to know more. And I think it's a discussion about risk benefit, like anything else that we do. We're looking at risk of hospitalization, risk of death, looking at what their risk for reinfection, which I think everybody's at risk for now, given the lack of distancing measures now and how contagious our current variants are. But this is just a very brief discussion about some of the side effects related to the COVID-19 vaccine. And as an allergist that is being asked to assess potential reactions, we still are waiting for effective guidance. And the guidance that we've mostly received has been on an individualized basis, understanding our patient and their risk for infection, and their risk for complications of infection should be weighed against the potential or prior adverse effect of the prior dose. So why are we talking about vaccines now? We are 2 years into the pandemic. Testing has been almost removed from many areas of the world with respect to travel. Everyone is in this new mode of vacationing, meeting, interacting, catching up from their last 2 years. And we want to push this pandemic behind into the rearview mirror, but this is not happening. What we're seeing is that we do have the potential for the emergence of new novel variants this fall, as we start to see in the Northern Hemisphere, as we go to increased indoor activity. We will anticipate a waning immunity in the population with respect to prior infection or immunization, which will then create a perfect environment for an increased risk of a major COVID-19 outbreak. So let's think ahead, and we have to kind of keep our eye on what is happening now in terms of predicting where we're going to be in the fall. And so this conversation now leads to the variants of SARS-CoV-2. And I had shown this diagram at an earlier meeting, and I want to talk about BA5 or BA4-5, which is this red divergence right here. So while BA1, which is right here, is much closer to the BA5 than the original Wuhan strain, it still has substantial dissimilarities. And what we know is that the BA4-5 subvariants are spiking globally because they can spread faster than any other circulating variants. They have the capacity to infect people who were immune to earlier forms of Omicron and other variants. The significant impacts from BA4-5 can be seen recently in Portugal, where COVID-19 vaccine and boost rates are very high. There had death and hospitalizations with respect to BA4 and 5 that was similar to those in the first Omicron wave. So we're talking about an immunized population, and now you have a new subvariant that's causing the same level of death and hospitalization. This is concerning. Antibodies triggered by vaccination are less effective of blocking BA4 and 5 than they are at blocking earlier Omicron strains. So this is the immune escape, including BA1 and BA22. And that could leave the vaccinated and boosted people vulnerable to multiple Omicron infections. So I'm not saying this to create alarm. I'm just saying that we can't lose sight of where we are right now. And we kind of have to keep our ear to the ground in terms of figuring out where we're going next. So this was published in the New York Times in terms of what this BA5 subvariant means for the United States. So I had mentioned Portugal. So you can see the BA5 variant here in this blue color. This is Portugal, this is France, and this is data between January 1st and July 4th. You have Italy over here, and you can see the United Kingdom. The CDC says so far that BA4 and 5 is there's no evidence that it is more severe than any Omicron subvariants. However, if more people become infected because it is highly communicable, the number of people hospitalized because of the virus may rise. And so where are we right now? So this is data in terms of July 2nd. And now you can see that BA5 is almost up to 50%, if not at 50% right now, in terms of the variants that are the variant of concern that is circulating. It's actually 53.6%. So I had mentioned that the vaccination is not as efficacious. So now this is looking at the 2 doses of Moderna versus 3 doses of Moderna. So this is just the first booster dose. I'm not talking about the second booster dose here. And you're looking at the vaccine efficacy in terms of Omicron, which is in red, in the red line, or Delta, which is in the blue. So this is with respect to 2 doses on the left and 3 doses on the right. And what you're seeing in both cases, whether or not you got 2 or 3 doses, that the Omicron, which is in red, that the Moderna vaccine was found to be less efficacious against Omicron. So the current viruses are antigenically distinct strains that are circulated in the pandemic on which the current COVID-19 vaccines are based. And just to disclaim, share, I got these slides from that FDA meeting that had occurred on June 28th. So this was the summary of data that was presented to the FDA. So the SARS-CoV-2 Omicron variant has become dominant globally, poses a higher risk of reinfection than previous virus strains, and continues to evolve into sublineages that are also antigenically distinct. By several measures, including escape from antibody neutralization, so I use that immune escape term, and protection against infection, the current vaccines appear less effective against Omicron variants than against previous strains of virus. The available data indicate that an Omicron booster vaccination will increase and broaden the antibody response to Omicron viruses. So we had talked about the second booster dose in those who are 50 and older in terms of predicting death. But here I'm going to also make an argument that this is also why whatever vaccination programs are available and you are eligible for, this is definitely worth doing. So this got released on June 30th, but this was the committee vote that they were asked to make on June 28th. Does the committee recommend inclusion of an Omicron component for the COVID-19 booster vaccines in the United States? Now you can go onto the FDA website and you can look at the advisory committee actual meeting. It's on YouTube. It's all recorded, so you can actually see this yourself. And at the bottom, you can actually see all the votes that were put in regarding this, and there were 90% of the committee members that voted to include the Omicron component. So what they did was they advised manufacturers seeking to update their COVID-19 vaccines that they should develop modified vaccines that includes an Omicron BA.4/5 spike component to create a two-component, also known as a bivalent booster vaccine, so that the modified vaccines can potentially be used starting in early to mid-fall 2022. Okay, so let's unpack that a little bit. If these companies are now being asked to make a booster dose that includes the original vaccine variant, including now the second component, which includes the Omicron specific, and that this be available in the fall, and you're eligible for your second booster dose, it would make sense to get your second booster dose now in July so that you would be 4 months out in the fall when this bivalent vaccine becomes available. If you delay your second booster dose later into the summer, you will lose out on the ability, based on the timing of your second booster dose, to get that new bivalent vaccine. Now, I'm just discussing one particular scenario. Every country will have its own vaccines, will have its own schedule, but I'm just referring to one way to view how to approach booster doses today if you've not already gotten it with respect to the anticipated bivalent vaccine. So this is the data that was presented by the Moderna president at that meeting, and talked about one specific bivalent vaccine that the original mRNA Moderna vaccine is known as 1273, and the bivalent vaccine is known as 1273.214. The ancestral vaccine contained 25 micrograms, and that included the second variant, which was the Omicron variant, that was 25 micrograms. So they met, and they have all the data that's on their website that I'm not sharing here. They met pre-specified primary and key secondary objectives. They had superior neutralizing titers against Omicron. They had higher neutralizing titers against the ancestral strain. They had a favorable safety and tolerability profile. And this is really important. They had higher binding antibodies against all alpha, beta, gamma, and delta variants. They had robust neutralizing titers against BA.4/5, including in adults greater than 65. And they had durable antibody responses within the bivalent platform. So they're expecting that this vaccine would be available in late July or early August. BioNTech and Pfizer. So now we are looking at something that we have at hand right now, which is to be for this fall. But we talked about efficacy of vaccines, efficacy of booster vaccines, the spread of BA.4/5, the immune escape of BA.4/5, and the potential risk of increased hospitalizations and death in an immunized population, which we had discussed as being community immunity or herd immunity in the past. So when you now have the need to create a bivalent vaccine to be able to address all the variants, that's where the earlier discussions that we've had on this platform about creating a vaccine is useful. So right now, that's the concept of the universal vaccine for coronaviruses. So taking a step back, and instead of making this, SARS-CoV-2 specific, but it includes all the coronaviruses. So this is news from a week ago. BioNTech and Pfizer said that they are going to partner in making next generation shots to protect against a wide variety of coronaviruses in the second half of this year. And it's to protect against severe disease if the virus becomes more dangerous. And we need that shot to protect against a broader family of viruses and its mutations. There was another paper that was also released in the past week, and that was about a nanoparticle vaccine. And this was looking at this vaccine in an animal model. And what you have is what is called mosaic 8, and that includes 8 different receptor binding protein areas that are included. This was a joint effort by Caltech and the University of Oxford in developing this vaccine. It uses 60 fragments of 8 strains of coronaviruses, including COVID-19, to make a broad spectrum of antibodies. Animals were vaccinated with the mosaic 8 nanoparticle, which made antibodies that recognize virtually every SARS-like beta coronavirus strain that was evaluated. And this was based on the statement from the Alexander Cohen, who is a postdoc scholar, and he was the first author of the new study. And they're expected to start phase 1 clinical trials over the next year using a 30 million grant from the Coalition for Epidemic Preparedness Innovations. So that's it for today. Thank you for your time. I hope you found that useful.
Monica, can I have Monica?
Thank you so much, Dr. Monica, for your lovely presentation. And I think we will open the floor for the question answers. Yes, Dr. Sajjad, please ask your first question.
Okay, thank you very much, Saurabh. Always, Monica is very fantastic, very informative presentation. So I have some query regarding the vaccination of third booster. People in Pakistan and other, I have discussed in other friends that they are very much reluctant for the third booster. Do you think, I don't find any comments from your side in your slide that the third booster is very, very effective. Secondly, at what time the third booster should be given after having the second booster? And thirdly, what do you suggest about the Omicron? Here in Pakistan, we have the clinical symptoms are running nose, sore throat, fever. Somebody have a slight low grade fever, and the other have a very high grade fever, and body ache, something very light symptom. But on the other hand, the people have a severe severity like the diarrhea, and some people have a vomiting and high grade fever with the respiratory symptoms. So what do you suggest in this condition? Either people should have the booster dose after having these symptoms. If they have to have the booster dose after having a small, little symptom, then at what time after subsiding the symptom of this light symptom like sore throat and common cold and running nose after having negative corona test? Yes, Monica.
Thank you so much for your questions. So I just want to clarify. So third booster, they received the initial series, which could be 2 vaccines. They received the first booster and the second booster. So they received 4 vaccines. And now you're asking me about the 5th dose. Is that correct?
Yes. Yes.
Okay, so we don't have any recommendations on a 3rd booster at this time, except for those who are severely immunocompromised. If I was to make a recommendation that is not based on any information that I have read, what we are seeing is the minimum time between doses to be 4 weeks.
4 weeks.
Yeah, the minimum time between doses. However, knowing that there is going to be an Omicron specific booster, which is this bivalent vaccine, if you're in the summer, maybe it might be worth waiting to get the new bivalent vaccine, although I don't know when it would become available. I gave you the minimum time. That's the minimum time that we know between 2 doses of vaccines. What they're saying is 4 months, right, for the second booster dose. So it would mean that if you wanted to get another booster dose, which is not under any guidelines right now, it would be 4 months after the second booster dose. Again, that's just based on what we know so far, but it's not based on any guidelines, and that would be my only recommendation. So any second booster dose at this point, third booster dose at this point is not something that I feel confident in being able to recommend. The second question you asked was about the variation in presentation of infections, whether it be mild to moderate to severe infections that doesn't require hospitalization, and receiving vaccination after infection. Now, we know that native infection does stimulate the immune system, both B cells and T cell responses, broad array, more than just to the receptor binding domain or spike protein of the vaccine. But we do know of hybrid immunity, that immunization following infection is the best immunity that you can get. And if we're seeing that there is immune escape from these the newer variants, what is it that I recommend for people who have infections? Now, we used to wait 3 months after infections when people were treated with monoclonal antibodies. But the data regarding immunization following infection doesn't follow that same thought process. I have recommended to my patients that two weeks after they've had an infection, that they can receive a booster dose. But I think that was before, when they were between the primary series and the first booster dose. If you've already received 2 booster doses and you've gotten infected, I really don't know what my recommendation would be about the 3rd booster dose. But I do recommend immunizations for those, even if they've had infections.
Okay, thank you very much. Yes, go ahead, Monica.
I was just going to make a comment too, and it kind of even speaks to like the vaccine hesitancy. And I might have mentioned this earlier in an earlier meeting, is that one of the theories behind long COVID is that you have viral particles or viral bits that are stuck in areas of clots, microvirus stuck in clots. And when you get the COVID vaccine, what you're doing is you're giving your immune system a boost to be able to clear those areas and to prevent or treat long COVID. And that's why some people might benefit with long COVID symptoms when they get immunized or reboosted. So when it comes to people who've had symptoms, whether it be mild, moderate, severe, and you get immunized, maybe you are addressing or attenuating the development of long COVID symptoms, no matter how severe the infection was.
Okay, Monica, one thing more I would like to ask is, the people are asking about some people are very much reluctant after having the second basic vaccination, or 2 vaccination, no booster dose. Then they are now convinced with the second with the booster dose, but they have more than 8 months with the basic dose. So is it the time to have the booster dose? Any harm on delaying having the booster dose?
They are absolutely eligible for getting the booster dose. Reason one, 8 months since their dose. Reason two, immune escape from the COVID variants. Reason three, 4 times reduction in death over the age of 50, seen with the second booster dose, first booster dose, even more so. I do believe, and that's why I wanted to talk about the vaccines today, is that we should not be complacent. We are still in the pandemic. We don't have real numbers in terms of who are infected because many people are not testing anymore because their symptoms are milder. But we are all at risk for getting infected and reinfected. There's going to be more and more data coming out with repeat infections, people who've had second, third, fourth infections, irrespective of immunization status, because of BA.4/5 that's now globally circulating and has immune escape. And you have the acute death, subacute hospitalization, and chronic long COVID complications. So I don't think we understand the full impact of every infection. So to risk stratify and to minimize risk, I think immunization is the best tool we have.
Okay, thank you very much. Saurabh, if you permit me, I just want to announce about the upcoming CMAAO.
Dr. Sajjad, we will take it. We have a lot of questions. We'll do that after the session, or between the session.
Actually, Saurabh, I have a commitment to go to hospital. So I will take a minute. Just to request all the worthy participants, to come to Karachi, Pakistan, to attend this CMAAO meeting in Karachi, 23rd, 4th, 5th September 2022. And I request all the participants, if interested, to present any subject they want to present. Please do let us know so that we can arrange the time and slot for them. My regards to everybody, and thank you very much.
Thank you, Dr. Sajjad. Thank you so much for the announcement. Dr. Angelica.
Morning and morning. Good night to you, nearly, Monica. Thank you again for a very interesting and thought-provoking lecture that you gave us. So, Monica, I have done a lot of research because I was recently involved in a CCMA case where I had to help the employer against an employee who didn't want to be vaccinated. So I looked at a lot of the data as well. But there's still one concern, and this is my personal opinion. I'm still very much concerned regarding the vaccines. I know the vaccines, and I agree with everything that you have said. But my concern is that the majority of people get mild disease. And if we look at the data for vaccines against mild disease are not very great. The data against severe disease are great, and there's no question about that. But if one speaks to the average population out there, the average person out there, they will get mild disease. And they then also start to question, why do they need to get boosters? Because in any case, going to get mild disease, I know there's a chance that they might get severe disease, and we all know that risk. But for the average person out there, it doesn't really make sense, all these boosters that you get to prevent you from dying, especially if you are younger. And maybe we need to think how we package this to the population out there. And so that's my one concern is, doesn't matter how many boosters you get, you still will get a mild disease regarding the current data. So, and then the second thing is, when patients come to me and ask me and say, yes, doctor, I was very sick after my booster or my second shot. And why does that happen? How do we answer that in the right way? I always say that's your immune system. It's showing you that you would have gotten worse sick if you had the original or the real infection. But I know that's not correct what I'm saying. It is hard to say to people because they don't understand that's an inflammatory response that your body's got. How do we package that as well? I think if we can package that correct, and the mild disease, doesn't matter how many boosters you get, maybe we will get the vaccine hesitancy being less going forward. That would be my 5 cents worth this morning. Thanks, Monica.
These are great questions. Okay, but I think I have an answer for both of them for you. Okay, so those who say that they'll have a mild disease no matter what, I am actually going to draw this conversation back to Dr. Agarwal. When he was vaccinated and he had a sense of confidence that the pandemic had been moving forward and he was vaccinated, he got caught off guard. It reigned Delta in a genetically susceptible population in Delhi, where those who were older, at risk, who had received complete immunizations, faced an incredible death rate. If you can count and go back to April, May of 2021, they didn't know. So we don't know what's going to happen, right? That virus is going to change. So we don't know. When in South Africa, Omicron first came out, and we're looking at B4, B5 data of South Africa compared to Portugal. The data for South Africa is very different for the hospitalization and death rates in Portugal. So as we look at variants and we look at genetically susceptible populations, and we look at vaccination rates and time since vaccination based on indoor-outdoor behavioral patterns, based on what season we are in, that was why I showed you that graph, is that maybe, yes, 90% of the people who get infected will be fine. But what if you get caught off guard? What if it rains the new Delta in your country? That is what I think the question is. And we're looking and we're beginning to see. This was not a conversation that I would have had, before B5 was really emerging. And the reason that we just need to talk about it right now amongst ourselves is A, we protect ourselves, we protect our colleagues. And then we look at those who are receptive to the information in our patient population and in our communities. But that doesn't necessarily mean that we're going to be able to convince everybody to get the second booster dose. But it's our job to be able to identify those who are willing to listen as to why we're talking about this. We all want this pandemic to be over. We don't want to be talking about vaccines anymore. We want to be able to study and bring back the standard of care for all the other chronic medical conditions that have affected our patients, just like this pandemic has. But if we had the ability to provide the right amount of immunity at the right time and match it from when you had a variant surge in your environment, we will be golden. Everything is a mismatch, right? There's a mismatch between the availability of vaccines when we're giving out our vaccine rollout, and what the surge is going to be. And that's a question I'm answering to you right now. Patients feel like the disease is mild right now. They don't feel compelled to get the vaccine. But when the variant becomes completely much more contagious or much more causes much more morbidity and mortality, then we're going to be behind when it comes to getting the vaccine doses. I think when we get to the pan-domain vaccines that I talked about earlier, I think that's where we're going to be able to start feeling like, okay, we have the immunity that we need. If we had perfect medications to treat, that would be fine. We wouldn't have to talk about this. But when we don't have the availability of perfect medications, or a lot of contraindications to medications, this is why you want the vaccinations. So right now, I'm just appealing to those who have medical knowledge and who have interest and desire as to why it is important to get the second dose of the vaccine, or to continue to keep looking at vaccines while we keep our eye and ears to the ground regarding the variant and where we are with hospitalization rates. I feel like we are not getting all the information. I don't feel we have a true picture yet of what the impact of the pandemic is. But maybe this is just a small blip and everything will get better in a little while. Or maybe we're at the beginning of more than just a blip, and it's going to continue to rise. I can't predict that for you. So that is the answer in terms of why, how I would address the concern that most people are having mild infections. And then the morbidity associated with long COVID, I want to say something about that. So as an allergist, I treat patients with chronic rhinosinusitis with nasal polyps. Anosmia is a big symptom. So I've been asking about lack of sense of smell and taste for years in my patients. When they get put on medications that return that sense of smell and taste back to them, or if they've had polyp debulking surgery, they tell me about the quality of life that they have. We are talking about long COVID symptoms as simple as anosmia that's affecting these patients' lives. If vaccination can help that or prevent that, then that is also worthwhile, even though it's a mild infection. Okay, I'm sorry, I feel like my volume is low. Somebody has told me that. Can you hear me?
No, we can hear you. It's okay.
Okay.
The volume is fine.
Okay. Now, talking about why do I get sick after the booster dose and what is it that I use to educate my patients? I tell my patients that getting vaccines, booster doses, is like getting a degree for your immune system. Either you're getting primary education, or you're getting secondary education, or you're getting a PhD. So every time you get exposed to the virus, whether it be vaccination or infection, you're getting a more sophisticated degree. The problem with getting the degree is that you will feel sick. There is going to be some sort of effect of the vaccine that makes you know that your body has appropriately responded to it. So that is how I explain it to my patients, is that the reason that you get sick is because your hormones that are released in response to the vaccine is going through a dry run as to how to treat or face the real virus when you come across it. And when you have side effects with the vaccine, can you imagine how sick you would have been with the real infection? I hope that answers your questions.
Tarav, can I ask the questions now?
Dr. Chong, and then you can ask
Okay.
Dr. Chong. Yeah.
Hey, hi, Monica. Sorry. Thanks for that beautiful presentation. Hey, I just want to ask about the 4 times and the 42 times for those above 50 for the 4th dose, or the second booster dose. Where did that statistic come from? And it's 4 times compared to unvaccinated, or is it 4 times compared to 3 shots? Those who received 3 shots versus 4.
Okay, can you see the slide? Can you see the slide?
Yeah.
Okay, so this is coming from the CDC response team. And it came from the task force. So this was data released by the CDC. I'm sorry, I didn't put the link in there where I got this from. So this is looking at data just from the month of April. And what they saw is that in those who were 50 and older compared to unvaccinated, this is the black line here, 42 times more risk of dying from COVID-19. And if you were 50 and older, vaccination with primary series and 1 booster. So in most people, that would be 3 doses, right? 2 doses Moderna, 2 doses Pfizer, plus 1 booster. They were 4 times more likely from dying from COVID compared to those who had gotten the second booster dose.
So this is actually the 4 times differential is 3 doses versus 4 for the mRNA,
Yes.
for the
Yes.
mRNA, right?
Yes.
I had a look at the Israeli data, and the Israeli data shows that it was the 1.2 million Israelis that had 3 doses and versus 4, and it was 2.6 times severe disease, less severe disease and death. So it was very interesting. The Israeli data is 2.6 times, and the US data is 4 times.
Right, because their data is going to be time-stamped based on where you are in terms of your population immunity from your vaccine rollout. And it's also going to be time-stamped based on where you are in the pandemic in your region.
Yeah. I'm asking this because I'm facing the decision soon after it's been 90 days since I had COVID. So I need to take my 4th shot. So I'm asking, I'm trying to decide whether is it Novavax, Pfizer, or Moderna.
So I don't have an answer for that one because the Novavax had great data. Yeah.
I've done 2 Pfizer. I did a Sinopharm and you know, the Chinese vaccine. So and then if I do the Novavax, I would have done everything, including getting a COVID infection.
So 3 platforms plus native infection. Yeah, which was probably Omicron. Yeah.
Thanks very much, and I'm sorry you were a bit you know you were a bit choked up just now about Dr. Agawa, and we all feel the same way too. Thank you very much.
Thank you, Dr. Chong. Dr. Ravi.
Thank you, Monica, for your wonderful presentation as always. I got 3 questions. Number 1, Pfizer BioNTech and Pfizer Comirnaty, are they the same?
Yes.
They're the same. Okay.
Oh, wait. Pfizer BioNTech, yes, is the same as a Comirnaty. Yes.
Okay.
I don't use that.
Okay, because here in Malaysia it's Pfizer Comirnaty. They refer it to as Pfizer Comirnaty. Okay, the next question is, what can we expect with the new Omicron variant and the new wave coming? And what is the main factor for these cases to rise up again? Because it's just spreading like wildfire now. And what activities should be cut in order to prevent this from spreading?
So those are great questions, and I don't have very specific answers for you because I think it's too early to tell. We do see that rates of hospitalizations have gone up around 15-20% in certain areas. I think, you know, if you look at California or if you look in very high populated areas where, you know, there's lots of travel, those might be markers. We saw, and I alluded to the fact that BA.4/5 didn't have the same impact on South Africa as it did in Portugal, and people kept their eyes on Portugal. But in terms of what I recommend be vaccinated to wherever maximum level you can get, right, as recommended, and then choose your travel carefully, and choose your travel carefully based on where you are on your vaccination status. I'm not eligible for my 2nd booster dose, and I'm going to be traveling this summer, and I'm just wondering and hoping that the indications come out for a 2nd booster dose for my category. But it is definitely worth, you know, timing your immunizations also to give you the best boost right before you travel, and that when you travel, maybe travel with a mask. And then when you get to areas that are more open in the warmer areas, then you not wear a mask. But I will tell you, nobody's wearing a mask anymore. Nobody wears a mask. I go shopping, no one's wearing a mask. I travel, there's no one wearing a mask. The only place that I wear a mask is at work.
But what can we expect with this new Omicron variant? I mean, you know, a new wave coming.
Yeah, I don't know, because if we get the bivalent vaccine and say the bivalent vaccine comes end of July and in August, and people start receiving it, I don't know how the availability of that vaccine will impact the variants that will develop.
Thank you, Monica.
Dr. Jamal.
Yeah, thank you so much. Actually, Dr. Monica, thank you very much for your nice presentation on this. Actually, I have several questions actually, but I don't know whether the time constraint will be permitting me. Number one, actually, what in your presentation I have seen that you have shown that due to traffic accidents, there are a lot of more death cases actually in the US. But whether it was compared with the lower mobility during this lockdown period, whether, I don't know whether it was compared with that or not. Number two, in US, I have seen in 2019, influenza, the death due to influenza was number of cases were 38,000 a year. That means more than 3,000 in a month. So this, actually, now the COVID-19 now, they are causing, I think, less deaths in US. So maybe not pursuing those COVID protocols and not obeying those things, following those things, maybe one of the reasons that the people of US, especially because they have got the data, but we don't have the data. Don't know how many deaths are due to influenza in our country. But even then, I think this may be one of the reasons why the people are not just following the protocol. And the one more thing, actually, I got a call just now, my personal experience. One of a friend, actually, he had this COVID-19, and he became negative after 3 weeks. Definitely, it's very unusual. But he was complaining of severe, this weakness and others, something like that, follow-up of that COVID. He is not hypertensive, and he is just pre-diabetic, and he was asthmatic actually for a long time. So and the other observations, actually, I stayed with one person actually for a long time, something like that, 2 days, you can say. And of course, we are masking most of the time, but not all the time. During the meal time, definitely we are not having mask together. But he was tested positive after 2 days. And another incident I have seen that some people actually were just journeying together, and 2 of them were just having the positive, the others were negative, and they didn't contract the disease. I don't know how we'll explain all these things. Actually, they are not using the mask actually most of the time. So these are the things. And about the long COVID, actually, even the case that what I was telling you, that even if it's a mild case in the Omicron case, but how is the chance of long COVID and severe long COVID? Thank you.
Well, thank you for your observations. You mentioned a lot of points. The first is I drew up the slide again, and it wasn't specifically about motor vehicle accidents. It was accidents in general. So any accident, an accidental death is listed here. So people were still driving during the pandemic, even though we were on lockdown for essential people. I was still driving to work, right? Or on days that I had to go to work. So there was still travel that was happening. Now, in terms of duration of infection and duration of symptoms and duration of positivity, that was another comment that was made regarding our current recommendations of 5 days in isolation and 5 days with mask. We are seeing that as the pandemic evolves, as this variant evolves, the duration of infection may also increase. And that, again, I'm going to mention again the genetic susceptibility. We don't know in terms of host factors whether or not that you are just carrying the infection longer because A, you got a larger dose of the initial vaccine, of the virus, or the virus itself is inherently staying in you longer. You talk about house guests that are sitting on the same table, and some people are getting infected and some are not. Well, again, lots of variability in terms of where you are sitting on the table, whether you're in the direct line of the person talking, where your state of immunization is, when you got your immunization. Again, vaccinations are not meant to prevent disease, but they're prevent infection, but are meant to prevent severe disease. But again, in those people, you will have multiple issues. You must have had patients who've told you that in a household, there will be, multiple positive members and there'll be one member who never tests positive. There's also information that Omicron has a sensitivity rate of 60% on rapid testing. It's not 100% on rapid testing. You need confirmatory PCR testing in a lot of cases. Even if it's an asymptomatic case with exposure. So that's why it's the real data in terms of the burden of infection is really not known. I hope I addressed some of the questions that you had. Yeah.
The question says, how long does the COVID-19 booster mRNA vaccine immunity last?
So good question. That depends on your immunity. It depends if you have hybrid immunity from a prior infection followed by immunization. I would say though that the immunity from vaccination or immunity is like 3-4 months. And you would assume after that point that it's starting to wane. So you might have some immunity, but it's not going to be as robust as it would be 2 to 4 weeks after an immunization, complete immunization.
Monica, I was looking at the Israeli data, and it's very interesting that even with the 4 doses of mRNA that they did in Israel, it did not stop them from catching COVID. It just reduces hospitalization and mortality and severe disease. But it did not actually, I think the protection waned after 4 weeks, after the 4th dose of mRNA. It's so like the rates of infection did not drop.
So I agree with you. So I talk about vaccinations as wearing a seatbelt in a car.
Yeah.
In a vehicle. It doesn't prevent you from getting into a car accident, but it'll protect you. And then everybody's going to have a different sized vehicle. They'll either be sitting in a passenger car, in a motorbike, in a truck. So that could be how strong your immune system is or your baseline health status. Your accident can also be of varying strengths. You could be hitting, you could be driving 10 miles an hour. You could be driving 50 miles an hour or kilometers per hour. And so the impact of the accident is different. But vaccination is only wearing a seatbelt. If you're a careful driver, you wear your mask, you do social distancing, that kind of stuff, then maybe you won't get into an accident. So I use that as a way to explain it to my patients as well, that we are not using immunizations to protect infections. We're using immunizations to prevent dying from infections. And you don't know. You don't know.
So, Monica, can you be certain that initially, after the vaccination started, there were complaints of blood disorders? Now you can just rule out those things because you have not shown anything like that.
It's because of the vector-based. That's why the Johnson & Johnson vaccine is not recommended in the US. And so they found to have a higher risk. But I will never say that any vaccine is 100% safe. It's a discussion like anything else we do, which is risk-benefit, right? Paracetamol is not safe for someone who has liver disease, but paracetamol might be the analgesic of choice for someone with kidney disease. So again, that's why we're physicians. That's why we take care of our patients. We understand the risk in terms of the patients that we're treating. So I would treat a person with a BMI of 45 with coronary artery disease, with multiple comorbid conditions differently with respect to a vaccine discussion rather than somebody with a normal BMI who's 19. Again, there's a lot of factors that go into the discussion.
If we don't have any more questions, I think it's more than a midnight for the speaker, and she still smiles, but yeah. A very good and nice presentation, and I think many questions which were pending for last so many weeks Thank you for answering those questions, and many more sessions to come forward. So shall we wind this session? I think we are already 1.5 hour session crossed. So thank you, Dr. Monica, for the wonderful presentation and the answers of all the questions. I'm sure there will be a lot of questions going forward as well when people sleep over it and they think about it. So many more sessions. Next session will be on nutrition. So we will announce the speaker very soon. Thank you so much, everyone, for joining in. And see you next week again. Same time, same day, same place.
Thank you.
Thank
Thank
you.
you, sir. Thank you.